Good morning, everybody. Welcome back to my image evaluation series. Today, we're going to go over a chest x ray. Chest x rays, we do two views. We'll do a PA chest with the patient's chest against the image receptor, and then we'll do a left lateral with the patient's left side against the image receptor. Chest x rays are done at 72 inches versus the normal 40 inches. And the reason we do that is to minimize magnification of the heart. We want to get that heart as close to the image receptor as we can. Uh, so let's talk about a chest x-ray. And again, we'll be using the Paceman critique method, and we'll go through each one of these images just so you're aware of what we need to see on a chest x-ray. Now, a chest x-ray is the one that we do quite often. Especially during the cold flu season, people develop pneumonia. We do a lot of chest x-rays, so it's important to know what needs to be there when you do a chest x-ray, so you're not cutting important parts off or allowing for too much rotation where the diagnosis takes a little bit of a vacation. When that happens, you're not able to see what you need to see. So it's very important that you know what needs to be there. Okay. All right. So let's move on to this first picture. It's a PA chest x-ray. Okay. Position wise, we seem to be in pretty good shape. The patient is fairly straight on the image, standing straight up and down. Very little rotation. And the way we can see rotation, guys, is if we look at the sternoclavicular joints on each side, okay, they should be symmetrical. So the distance between this joint and the spinous process here and this joint and the spinous process here are fairly equal, meaning that they're not rotated to one side or the other. If you see foreshortening of one of the clavicles, it just means that they're probably rotated towards that side. It's important that we get the patient as straight as we can against the image receptors so that we don't have any rotation. Rotation wise, we're good. On a chest x-ray, it's important that we see the lung apices right here, which is the top of the lungs, right? And it's also important that we see the costophrenic angles down here. And now if we're cutting either one of those off on this image or the lateral image, we need to retake that image. It's important that we see the entire lung field. Okay. Scapula wise, we've done a pretty good job. This patient has rolled her shoulders forward fairly well. We can see the scapula right here. We can see the border coming down through there, and we can see it a little bit less here. We want to try and get the scapular bodies out of the lung field, right? And that's accomplished by rolling the patient's shoulders forward. And they've done a fairly good job here. You don't see a lot of superimposition of the scapular body in the lung tissue. So very, very nice. We're able to see the heart silhouette here. You can see the aorta right here. It's kind of nice. It's kind of neat picture, actually. It's got some calcifications around the edges of the aorta right here. Now we can see the trachea coming down, filled with air, and you can watch that come down and bifurcate into the right and left perspective lungs. Okay. We can see good tissue here, which we'll talk about in the exposure end here. But position wise, it's very good. We're able to see what we need to see, which is what's important. So area, yeah, like I just said, we're able to see what we need to see. We've got the area that we need to see. So apices and costophrenic angles, right? Okay. Collimation wise, you can see the collimation on here is fairly good, I should say. I really wouldn't do anything different. We're able to see, an inch to 2 inches above the apices here. and we're able to see down below the costophrenic angles. We can see the liver right here in the diaphragm. Now we can see the stomach here, little gastric bubble right there, and then come down into the costophrenic angle right here. So yeah, collimation wise, it's perfect. Very, very nice. Exposure wise, this is more of a contrasty chest x-ray. And as far as penetration goes, the way you can tell if you have good penetration on your chest x-rays is you can look at the spine. And if you're able to see joint spaces between the vertebral bodies, you've done a pretty good job. If it's too light that you can't even tell that there's a spine there, you'll probably need to retake that image. And if it's too dark, it's going to burn the lung tissue out and they're going to look black. In that case, it's overpenetrated. But a lot of times at that point, you can fix that through post-processing. But when it's too light, there's just not enough information there to change that. But exposure-wise, pretty good. It looks like we used maybe a little bit lower KVP, giving us a little more contrast. And our mask setting is probably pretty close. So a little bit higher KVP. Most of our machines are set at 110 KVP for a chest x-ray, which is optimal. So unless you're shooting a kid or somebody with emphysema, use that 110 KVP and adjust your mass accordingly. So like I say, if you've got a normal size patient, whatever comes up on the machine is going to work just fine for you. Okay. But exposure, yeah, it's good. I mean, we're able to see lung tissue and the markings that come along with lung tissue. We're able to see the conglomeration around the heart area. Okay, sorry about that. Okay, and say good sharp edges between lung and bone. We're able to see ribs through the bone. So exposure is pretty good. Okay, good job. So let's run back to area. There's something I failed to recognize here. So we need to be able to see at least 10 posterior ribs on a PA chest x-ray. It just helps us determine whether that patient has taken a good enough breath. So here, this is the first rib, the one that kind of makes a C right there, right? Okay. 2, 3, 4, 5, 6, 7, 8, 9. We're almost to 10. Now, I would never redo this because we're really close to 10. But if you're, only getting 7 or 8 ribs on your PA chest, first of all, talk to the patient and make sure they're doing the best that they possibly can. And if they absolutely can't get a bigger breath in, just go with that image. If the patient feels like they can take a deeper breath and then open that lung field up a little bit, by all means, retake that image. Because realistically, a PA chest only showing 7 or 8 ribs is not sufficient. We need to be able to open those lung fields up so we can see what's going on in there. Just a little tip for you. Just remember, you want to try and see 10 ribs above the diaphragm through the lung tissue. If you've got less than that, talk to the patient, see if they can do a better inspiration for you. If they can't, send that image in and put a little blurb in your history saying this is the best breath this patient could take in. And if they feel like they can, by all means, take another picture. It's that important. Okay. So marker, yep, we've got a left marker up here. It's out of the anatomy. It's in the proper position. It's just like I say always, that patient is looking right at us. So that patient's left is our right. Okay. So we can see that the heart is on the left side. And I will say this, chest x-rays are pretty important that you use a marker on. It's very rare, but sometimes you'll have a patient with a condition like situs inversus where the organs are flipped. And if you didn't mark that image, you could just flip that image and make it look right. But in all actuality, it's backwards. So try to use your markers on the image receptor on a chest x-ray. Okay. Okay, very good. Aesthetics. Yeah, it's a nice picture. I would not redo this one. The contrast is good. The density is good. We're able to see the entire lung fields. So yeah, nice chest X-ray. This is what your PA chest X-ray should look like. Okay. All right, let's skip down here to the other PA chest X-ray. This is actually the same patient. This image was redone. Well, maybe it wasn't redone. Maybe it was done a couple weeks prior. But there's a couple problems with this image. We're not going to go all the way through the critique, but I'll just kind of show you the problems that we're having. So first of all, our left marker, good job using a marker, is right in the middle of the anatomy or the area of interest that we're looking at. So in a perfect world, that left marker needs to be up here out of the way, okay, out of the anatomy. Second of all, the image is annotated incorrectly. Okay, we want it so that patient is looking at us. This picture says this patient is looking away from us. So we want to pay attention to how we hang our chest X-rays. We always want the left to be on our right or the patient's left, just like that patient's looking at us. Okay, so this picture actually needed to be flipped, so the left showed on the left side. Okay, so we got the marker and the annotation is incorrect. And you'll note down here at the bottom that we have clipped the costophrenic angles. Okay, we need to make sure that we include the entire lung field, right? And I wanted to show you this image just for the fact that it shows some anomalies that we don't need on that picture, right? Okay, so when you're taking your picture, your marker ends up in the middle of the lung field or it's backwards, you know that you need to do something with that. I think part of the problem here is the centering point is a little bit high. The centering point for a chest X-ray is T7. You need to know that for tests. It looks like our centering point was more around T4 or 5. So if we'd have moved that down to T7, that would have moved the apices up and the costophrenics up as well. Okay. All right, cool. Let's move on to a lateral. Let's critique that. Okay. Here we have got a lateral chest X-ray, left lateral to be exact. Okay. Now, position-wise, okay, we're able to see the entire lung field again. Okay, it's exactly what we need to see. We've got costophrenic angle down here. We've got anterior sternum, skin margin up here. We've got the entire back on there, right? Ribs are stacked on top of each other the way they need to be. And we've got the lung apices. And you'll note that we're going through shoulder here. So we've got a little bit of quantum model there or graininess. There's not much you can do about that. You can try and hit them harder, but you run the risk of burning the lungs out. So this is actually a really nice image. Okay. So the area, okay, yep, we're able to see the area that we need to see. Okay, we're able to see the entire lung field, which is what we want to see. Okay, collimation wise, we've collimated very well. We're not including too much up top. We're not including too much down low, right? Yeah, yep, collimation's good. We're nice and tight to the back. We're nice and tight to the sternum. But we're still able to see what we need to see, which is gonna, if you collimate like this, it's gonna make for a good picture if your technical factors are good. Okay, exposure wise, yeah, good exposure. Like I say, you know, there's certain things that we can look for. We definitely want to see lung workings. Okay, and allows us to see behind the heart a little bit. Okay, you know, if there's ever a nodule or something hanging out down there where it's superimposed with the heart, sometimes they're hard to see. That's why it's important that we do a lateral chest X-ray because you can see back behind the heart a little bit. You can see the aortic arch right here. Pretty neat picture of that, and going down into the heart. Okay. We've got some space between the sternum and the anterior heart. We've also got space between the posterior heart and the spine, which is what we want to see. We really want to see the costophrenic angles here. Like I say, we've got good sharp edges between lung and bone. So it's a nicely exposed picture. I'm guessing, the KVP and mass were set properly. So marker, yep, we got a left marker up here. It's outside the anatomy stating that this is a left lateral. Aesthetics, yeah, this is a nice lateral chest x-ray. I love the way that the ribs are stacked on each other. That's what it needs to be. We don't have any rotation when those posterior ribs are stacked on top of each other. And I'll show you a picture here in a minute of what that doesn't look like when it's not quite right. We can see the sternum in profile. Yeah, this is a good picture. Arms are up out of the way as much as possible. Like I said, we've got a little bit of noise right here where we have to go through the shoulders, but that's to be expected. Okay. Another way you can look for rotation besides the costophrenic or the ribs, sorry, as you can look at the costophrenic angles, and they should be superimposed over each other as well. But this is what you want to see on a lateral chest x-ray, guys. Very, very nice. Let's go down here and look at this lateral. It's actually the same patient again, okay? But you can see that we've got some rotation going on here. We need to make sure that patient is at or perpendicular to the image receptor as much as possible. And it takes practice. I can put my hands on the patient's hip and I can tell whether they're fairly close to perpendicular or a 90-degree angle with the image receptor. Here we see some ribs that they're starting to swing out, right? They're not superimposed over each other the way they're supposed to be. This is the number one thing saying, hey, rotated, maybe we got to retake this picture so that the posterior ribs are stacked on each other like this. Okay, so when you see that, pay attention, get to know which way you've over rotated or under rotated. Okay, so you'll note that we can see the aortic arch better when the ribs are stacked against each other. Here, it just looks a little different. It looks a little bit bigger than it actually is, which can be a diagnostic nightmare. So make sure you're rotating your patients correctly, getting them straight up and down and perpendicular with the IR. On this one, we've also, sorry, my toolbar keeps getting in the way, but we've cut off the costophrenic angle down here. We don't want to do that. We want to include the entire lung field on every chest x-ray that we take. Don't undercollimate, but don't overcollimate either. Okay. So yeah, I hope this was helpful. Just giving you a good idea, and I know a lot of you have been doing this for quite a while and you do know what to look for. I just want everybody to be on the same page. So when I pull x-rays up and review those, I can see that people are grasping that we need to get the entire lung filled there. Okay. And when there are issues, know how to fix them. It just takes practice. And I really hope that you guys are taking the time to review this information that I'm putting out. I know that we're busy and clinic life is busy, but I still want you guys to do the best possible job you can with x-ray. I know it's hard when you come off the street and are expected to do x-ray, but that's why I'm here, and I want to help you, and I hope that you're taking the time to watch these and grow in x-ray. It's actually a wonderful field. And it's a good opportunity for anybody that wants to go down that path. And this is a good start for you. Anyway, thanks for being here today. Thanks for watching this. Next week, we'll probably jump into some spine stuff. That'll be interesting as well. But yeah, take these for what they are. They're here to help you. just so you're well versed on what you need to see on those X-rays. Okay, like I say always, if you have any questions, please give me a call. If I don't answer right away, I'll get back to you as soon as I can, or let you know that I can answer. And if you have any questions, I appreciate the calls that I do get. It just shows me that people want to do a good job and want to put out a diagnostic product, which is the bottom line. So anyway, have a good rest of your week and weekend, and we will see you next week.